Next, I'd like to introduce Dr. John Sayer, who will be moderating this session. Dr. Sayer is a professor of, this is not Dr. Sayer, but she will be in this session. Here he comes. Thank you. Dr. Sayer is a professor of renal medicine at Newcastle University in the UK. He has been an academic nephrologist for 21 years and specializes in studying genetics and molecular mechanisms underlying renal diseases. And John will introduce Hila. So welcome, John. Thank you for joining us.
Hi, thank you, Sharon. Thanks, everybody. Really interesting talk so far, and I've got the pleasure of introducing the next speaker. So this is Dr. Hila Rasouly, who's an assistant professor of medical sciences and associate director of education at the Center for Precision Medicine and Genomics at Columbia University. So welcome, Hila. Thanks moderating this session. I've got the easy part, you've got the more difficult part of giving us the talk, but
I have
great
the
to have you with us.
Because everybody else already covered, I think, almost everything I have to talk about. So it's going to be a review of the prior talks. Okay, so I'm going to talk about genetic testing in clinical practice and try to answer three questions: why, when, and how. So I think that Vonnie and Angela really explained the why, and Holly also had a really nice slide explaining why. And the how, the technical side of the how was reviewed by Guillaume, and I will try to talk more about how genetic counselors can help there, and how not everybody needs to become specialized in genetics. So why offering genetic evaluation to individuals with kidney diseases in general? I think, again, it was well covered, but there are all kinds of motivations. Some can be seen more as patients' motivations, some may be more clinician motivations, but probably it's like a spectrum. So it can create an informed and appropriate treatment plan. It can lead to appropriate extrarenal surveillance. It can determine eligibility for clinical trials, as was discussed earlier. It can obviously clarify the etiology of the condition, the why did we ever develop this kidney disease, elucidates the prognosis, what's going to happen to me, how fast I'm going to get on dialysis. It could provide access to reproductive planning option, as was discussed by Holly. Some places have more or less access to pre-implantation genetic diagnosis, but it is an option. It can help determine the risk of family members, which we call cascade testing, and was really nicely presented by Angela, who spoke about all her family members who were diagnosed following her diagnosis. Can provide access to disease community like this one. And it can end the diagnostic odyssey, which I think was, again, Vonnie really told us about her odyssey from 2019 to 2025. So I think these are all good reasons. There are probably many other reasons, and any motivation, any reason is a good reason to get genetic testing. Really, I think one of my main take-home points for nephrologists and other providers on the call is that you should not be the barrier between the patient and genetic testing. So even if you don't know how to do genetic testing, how to refer to genetic testing, that's something that you should know, how to refer to a specialist who will know what to do. So there are potential impacts of genetic diagnosis on actual clinical management. So again, going back to Holly's talk, there are things to do, even if there are no treatments now, they might be in the future. And it might inform kidney transplantation and the choice of the donor, if the donor is a family member. And it can also give access to family planning and to decisions around family planning. And as it was discussed, it might lead to new trials. So just knowing that you have a specific disease can make you eligible to a trial. And having more people eligible to trials increase the pace of these trials, because usually one of the most time-consuming part of a clinical trial is just to enroll patients. These are just three websites as examples. So the clinicaltrials.gov is usually for mostly phase 2 and 3 trials, but also phase 1 trials. The reporter.nih.gov is a website of all the research done and paid by the NIH. And these are just the 4 trials that research that are ongoing right now around ADTKD. And this is usually the step prior to the clinical trial, but it can also be the clinical trial itself, which is sponsored by the NIH. So clinical trials can be through NIH or through other organizations or through pharmaceutical, etc. And then in Europe, there is the Orphanet that is a good resource to find trials. So when should you offer a genetic evaluation, assuming that the patient is not asking for it, but you as the provider is the one who should suggest it to your patient? There are some red flags here that I'm going to highlight. They don't include the motivations that I mentioned earlier, but again, motivations are a good reason to offer genetic evaluation. So for instance, if you have a patient who doesn't have any of the red flags I'm going to cover, but is really worried about transmitting his or her kidney disease to her children, that's a good reason to refer to genetic testing. Okay, so some of the like well accepted red flags are first and foremost family history. So if your patient has a family history of kidney disease, which is relatively common, it is a good reason to refer to genetic evaluation. And I'm calling here genetic evaluation and not genetic testing because you may not be the one actually ordering the test, but you just want to refer to a geneticist or to a nephrologist specialized in genetics. An unusual clinical course in pink here is another reason to refer to genetic testing. If your patient doesn't look like your mainstream most common presentation. And any extra-renal involvement, anything that is not related, not caused by the kidney disease, but something else like gout or any others. The things here are not so much about ADTKD, but we would think about like early onset diabetes, for instance, for the ADTKD HNF1 beta form. Certain kidney subtypes, and I want to highlight here the unknown etiology is a major reason. So if you don't know why your patient developed kidney disease, it's a really good reason to refer to genetic testing. And then if you have a concern about a specific genetic condition, for instance, if you suspect ADTKD, it's a good reason to refer to genetic testing for ADTKD. So again, you found your patient, you think they could benefit from genetic counseling, but you actually only learn very basic genetics through medical school, fellowship, and licensing, and you are in a generalist nephrology clinic. What should you do? You don't have to become a genetic expert. You can refer to geneticists or genetic counselors, or you can refer directly to centers of expertise, which I will highlight at my last slide. Or you can choose to become an expert in genetics through CME courses, workshops, or you may want to take even advanced training. And there are now subspecialties in Europe. There is I think a 1 or 2 years training to become a nephrologist expert in rare diseases and genetics. And in the US, there are a few places that offer this type of advanced fellowship as well. So you may want, well, should I refer to genetic evaluation or should I order a test myself? Well, in the case of ADTKD, and let's say in the case of the United States, you may say, well, let me first order the general test that I have, a broad panel. I'm not sure what my patient has. If the test comes back negative, as Holly mentioned, that does not mean that it's not genetic. It might have been missed. As both Holly and Guillaume highlighted, the MUC1 variants are missed by regular tests, and that's a bit more complex. And you may not feel comfortable actually reaching out to Tony Blair and order it and ask him to help you out. So that's when you may want to refer to a clinician with genetics expertise who might be a genetic counselor or not. If you also feel like there are reasons for risk of adverse psychological impact of having a genetic diagnosis for your patient, that might also be a reason to refer to genetic counseling as opposed to ordering the test yourself. So for those of you who want to do the genetic testing, order the genetic testing yourself, I want to highlight the 4 steps of genetic counseling. But for those of you who don't want and just want to identify your patient and then refer them, the first 2 steps are actually should be part of the nephrology regular clinic anyway. So collection of medical history, that's part of any meeting with any physician. In this case, we want to formulate the most specific kidney disease diagnosis. Again, if we cannot, that's a good sign that we should be referring our patient to genetic evaluation, evaluate for extrarenal features, determine the kidney disease age of onset and the rate of progression are also important things. And here in the white bubbles, you have some questions that you should probably ask yourself and then ask your patient. And then the second part is family history. And I'm going to go deeper into both medical history and family history in a second. And then there is the etiology assessment, which can be done by, again, a clinical geneticist or a genetic counselor or nephrologist. And feels comfortable with that, where you actually estimate the probability of a specific kidney disease. You're going to formulate a differential diagnosis and think about which test to order. And then there is the informed consent, which is an important part of ordering genetic testing for patients. We want to make sure that the patient makes an informed decision to do the test. They need to understand the test, its purpose, the potential results, their impact on management and family, and discuss the process of testing and returning results, and the potential of having variants of uncertain significance, the potential of having a negative, unconclusive result, and what would be the next step in this case. So for in the case of ADTKD, for instance, if the broad test is offered as part of informed consent, there should be an explanation that there is a significant part of people with certain diseases that we need additional tests for MUC1 in the ADTKD case. Okay, so let's deep just in a little bit into the medical history. So again, these are the things that I already talked about. So you want to ask yourself, is the patient's progression of kidney disease typical? Is the age of the patient typical, or is it earlier? There is now kind of a expert-based agreement of 50 years old, but there was a recent paper showing that after 50 years old, you also find a lot of patients with genetic causes. So it's really a combination of any of the signs that should make you think about genetic testing, not everything at once. What is the most likely clinical diagnosis? Does the patient has non-renal disorders? When I'm talking about non-renal disorders, it might be eye anomalies or blindness, hearing loss, heart anomalies, heart disease, polydactyly, having 6 fingers, obesity, diabetes. And these are just some examples that none of them is ADTKD, but you could think of gout as being the extra renal for ADTKD, which again, not having gout is not a reason not to think about ADTKD, but it could be a reason to think about ADTKD. On the family medical history, and it's really what differentiates between genetics and any other medical subspecialty is that family history plays a big part here. So we need to collect 3-generation pedigree, 3 generations be including the grandparents, and as possible cousins. Understand whether there are other family members with kidney disease, are people passing away young. We may not know at a certain point that people passed away because they had ESRD that was not treated properly, but if they passed away young, then that's a sign as well. Are there other serious health conditions? Maybe another family member who's not diagnosed with the kidney disease, but something else that is associated with the syndrome. Is there any possibility that the patient's parents could be related to each other? And that's relevant for recessive diseases and not for dominant diseases. So just as part of thinking of a genetic diagnosis, you need to become a detective. And so you should avoid asking just, is everyone well? Because patients would just say yes. You want to ask very specific questions, and you want to be systematic to ask about each person in the family. You should look at your patient's body language to understand whether they know or they don't know. Often patients say that they don't have, that someone doesn't have anything when they actually have no idea if they have or not. So it should be explained to patient that it's okay not to know. They should make a difference between the two. Be sure to record the age, onset of symptoms, and collect information on major medical, physical, or mental health problems. Anyone needed treatment in hospital, serious illness or operations, miscarriages, or babies who are stillborn. So some examples of questions: how many siblings do you have? So that you start with them, and then you make sure that you cover all the siblings. Did you have any siblings who passed away? Or does your mother, father, siblings, aunts, uncles, grandparents have kidney disease or any of the other issues that you want to cover? Now, I realize that that's a lot for a 10-minute clinician meeting. Part of these things can be automatized. There are now all kinds of tools to collect family history. Some of that can be completed by the patient first and then reviewed. And you can also have nurses or nurse practitioners do that with the patient. As a genetic counselor, I think that drawing your pedigree can really help being systematic and making sure that you collect all the family history. And that's just to show you how we would look at that. So most commonly, people with a recessive disease don't have any family history, even though in textbooks we're always shown people with related parents and like highly interrelated family members. So there are multiple people, or they have multiple siblings. But since most of us don't have many siblings, and most of us don't have families or parents who are related, the most common form when it's recessive is that there is absolutely no family history. Similarly, in autosomal dominant, often there is no family history, either because it's de novo, it happened in your patient DNA and it's absent in the parents, or because the parents didn't share information with their kids, passed away for other reasons like accidents. But I would say that not sharing information between family members is probably the main reason why there is no family history. And then in the X-linked, which means that the variant, the gene that is causing the disease is on the X chromosome, usually women don't have a presentation, even though in the recent years, we see that more and more women have just a little bit of a different and less severe presentation. So my main takeaway point is this slide. You should refer to a genetic counselor if you're not sure, if you think your patient may benefit from genetic counseling and genetic testing. Genetic counseling doesn't mean that they have to have genetic testing at the end. This discussion that they're going to have with the genetic counselor, and then at the end, in informed consent, the patient is going to decide whether they want to get genetic testing or not. In the United States, there is a website called Find a Genetic Counselor that is provided by the National Society of Genetic Counselors, the NSGC. There is in-person and telehealth options. And when you're clicking on this website, you can actually go specifically to find genetic counselors who are specialized in nephrology. And going back to Orphanet, which is covering all the countries that you see here, so mostly Europe, but not only, there are expert centers, and so you can enter, and Orphanet is for orphan diseases, so rare diseases, and you can find experts in kidney diseases, or specifically even more for ADTKD. So I think I'm going to finish here. I'd like to thank you and thanks all my colleagues, and feel free to reach out to me if you have questions.
Thanks very much. So I'll start some questions while we're waiting for people to post their questions. But that was a really great overview. But I think we are all passionate about genetics and studying this disease. But I want you to answer some questions on maybe the negative sides of genetic testing, or the preconceptions about negative sides. So one is, like, when the sample's sent away, there's often a very, very long wait. So how do you reassure patients, during that waiting time, that, while things are cooking, what do you do in that scenario? And the second sort of negative point is, what do you do about people that say, this is for me, but I don't want you to worry other members of the family about this, in that scenario? How do you approach that conversation?
So from our interviews of patients, I think that if you give the patient ahead of time the time frame of when to expect the results back, usually we have a capacity as patients to kind of put it on the side and not to think about it too much, or kind of trying to focus on other things in our life, and as long as we know, as long as we are not close next to the email or the phone waiting for the response. So in the US, I would say now with the companies, takes about 6 to 8 weeks. So we usually say to patient, it will take 8 weeks, and then usually it's okay. But I think that the people here who had genetic testing can testify as well. Regarding the second question, so first of all, doctors cannot share with family members unless the patient is asking them to. And even if they ask them to, it's usually has to be done through the patient themselves. I think that having conversation with genetic counselors about why it's important to share with family members is warranted. I would really recommend referring to a genetic counselor to discuss that. Family communication can be complicated. Sometimes one of the solutions that genetic counselors have is to write like anonymous letter that patients can send to their family members saying, well, there is a genetic disease that was identified in your family. This is the genetic variant. If you want, you can contact, here is how to contact a genetic counselor to discuss it further, without actually providing the name of the individual who was diagnosed, if the individual doesn't want to be like the bearer of bad news in their family. But I think in general, this question of privacy and the confidentiality, it's important to make the difference between the clinical and the research side, and that in the clinical setting, the results are like any other clinical test. They belong to the patient.
That's good. Thank you. There's a question from Professor Matthias Wolf, who's a pediatric nephrologist, and he asks you, how do you think about ADTKD testing in children? So I guess pre-symptomatic testing. How do you deal with that?
So that's a great question. I think that today, the general consensus is not to test children unless there is a benefit for the child. So there are some, the people who say that the children should be tested are usually saying, well, the benefit for the child is that if the parents are less stressed out, it's beneficial for the child. However, they could be also more stressed out if the child is a carrier. Usually the reasoning not to do genetic testing for a child is that the child has the right not to know, the child has the right to decide for themselves when they reach 18. And that's, again, in the case of asymptomatic, which is different from Angela's discussion of her son. Again, I think there is room to have a discussion with the genetic counselors on the pro and cons. And overall, I think in most countries today, the recommendation is to wait for the age of 18. Now, all that could change if there is a treatment and the treatment is showing that early treatment is beneficial, then obviously all the discussion will be different if there is a treatment.
So I hate to interrupt because this is a fascinating discussion and a really, really important one. And so we do have other questions. Unfortunately, we won't have time to get to live, but we will, as I mentioned, we will answer them, post them on the website. One person did just ask quickly if you could share your contact information again.
Sure. I can share it, I think, in the chat with everybody. I'll put it now in the chat.
Okay. Actually, go ahead and share that. And then to the person who asked, we will post all the chat information on the website as well. So if you don't see it in the chat, which I'm not sure attendees can,
yes, they can.
They can. Okay, great. Thank you so much. I appreciate that. All right. So, and thank you, Dr. Sayer, for helping us understand better sort of the options for nephrologists and to consider all aspects, whether it's the upside downside of genetic testing, but sort of to help nephrologists and patients who are watching today get a sense of the full picture of what the benefits are, what the considerations are, and how it is a very personal decision. So we appreciate both of you for that today.